Hello, I'm Greg Stone from Mount Sinai Medical Center and the Icahn School of Medicine, and it's a pleasure to be here today to give you this talk on the update on the MitraClip, COAPT, and more. These are my disclosures related to the mitral valve space. Most importantly, as the principal investigator for the COAPT trial, I was uncompensated. So as you recall, the COAPT trial is the largest randomized trial today in the mitral valve space, and it was an ambitious study in which 614 patients with heart failure and moderate to severe or severe secondary mitral regurgitation were randomized to either MitraClip plus maximally tolerated guideline-directed medical therapy versus medical therapy alone. This is one-to-one randomization, and the goal really was to see if reducing secondary mitral regurgitation and heart failure in patients who remain symptomatic despite all other Class 1 guideline recommended therapies would interrupt the vicious cycle of volume overload, getting to more MR, getting to more volume overload, going to more LV dilatation, more MR, et cetera. Now, important is to note who we enrolled in COAPT. We did not want to enroll patients with the worst left ventricular dysfunction, such that the severity of the LV systolic dysfunction would totally dominate the prognosis. So we excluded patients with an ejection fraction of less than 20%, and perhaps even more importantly, we capped the size of the left ventricle as a left ventricular end systolic dimension of less than 7 centimeters. We wanted there to be truly severe mitral regurgitation, and this therefore had to be confirmed by an independent echocardiographic core laboratory before enrollment, despite all maximal med therapies, and this was using the multiparametric American Society of Echocardiographic criteria. As I mentioned, patients had to be symptomatic with either NYHA class 2, 3, or ambulatory 4, despite a stable, maximally tolerated guideline-directed medical therapy regimen and CRT and revascularization if appropriate. And we had an eligibility committee assess that patients really were on maximal therapy, but were still symptomatic, that is, failing those therapies. And we did have important exclusion criteria, particularly those with very severe pulmonary hypertension, not responsive to vasodilators, moderate to severe right ventricular dysfunction, or severe TR requiring surgery. Now, you know the results of the COAPT trial. Our primary endpoint was all heart failure hospitalizations with follow-up to 2 years, and there was a nearly 50% reduction in heart failure hospitalizations, highly statistically significant, with a p-value of 4 zeros and a 6. The average rate of heart failure hospitalizations was 68% per year in the control group and 36% per year after MitraClip treatment. The number needed to treat to prevent one heart failure hospitalization was only 3 patients. And this was an extremely safe therapy. The primary safety endpoint would have allowed up to 12% adverse events to offset that effectiveness outcome, and only 3.4% of patients had any safety issue at 1 year. So even more impressive, perhaps, was the fact that mortality was substantially reduced with MitraClip treatment. You note that in the control arm, nearly 50% of the patients died at 2 years. So this really demonstrates how desperate these patients are. And I mean, really, this is a mortality that's very similar to many cancers. But by reducing the left ventricular volume overload, even though the MitraClip doesn't cure these patients because it doesn't do anything about the underlying left ventricular dysfunction, you can see that mortality was reduced by an absolute 17%. So this is a 1 in 6 patients lived who otherwise would not have. The number needed to treat to save 1 life was only 6 patients. To try to put this into perspective with other class 1 guideline indicated therapies, if you look at just the HFrEF population, that is those with the ejection fraction of less than 40%, in the COAPT trial, there was only 5 patients needed to save 1 life with the MitraClip. In contrast, if you look at other therapies such as beta blockers, ACE inhibitors, mineralocorticoid antagonists, and neprilysin inhibitors, it's 20 to 50 patients to save 1 life in 2 years. So this truly shows how potent and life-saving this therapy can be in the right patients. We now have data out to 3 years, and here are the 2-year results. And following these patients out to 3 years, You can see that if anything, the curves continue to spread so that the death or heart failure hospitalization rates are now further reduced. And in fact, you can see the p-value has like 10 zeros followed by a 1. And I only show that to point out that this is beyond the shadow of a doubt that this is a real statistical finding. The number of needed to treat to prevent one death or heart failure hospitalization was 3.4 patients. And a unique aspect of this trial was that at 2 years, crossovers were allowed in the surviving control arm patients to receive the MitraClip, which was provided for free. So this slide, as you see it right now, includes those patients in the control arm by intention to treat. If we remove those patients, you can see here are what the data look like. And now if we look at the outcomes of those patients who crossed over at 2 years from the control group to receive the MitraClip, and we restart their outcomes at time 0, now you can see they basically reassume the death or heart failure hospitalization rates as the MitraClip treated patients. So the important take-home message here is that it certainly is better to treat these patients earlier rather than late, but it's never too late. That patients with heart failure, refractory on medical therapies are still going to benefit whenever you can reduce their LV volume overload with a MitraClip. Now, the real reason that the benefit occurred was because of the reduction of MR. And this is a busy slide, but what it shows is the severity of MR in the 2 different arms at baseline, 30 days, 12 months, 24 months, and 36 months. And at every time period after baseline, there was a marked reduction in MR grade in MitraClip treated patients compared to medical therapy treated patients. And even more important, perhaps, was the fact that the recurrence rates were less. And if you look here at just the recurrence rates to 3 or 4 plus mitral regurgitation in the MitraClip arms, you can see that it's like 7% at 30 days and then 5% at 12 months. And then about 0.6% and 1% at 2 and 3 years. So very low single-digit recurrent rates of severe MR. And that's because the MitraClip actually treats the underlying pathology of secondary MR, which is lack of coaptation of the anterior and posterior mitral leaflets from the tethering from the spread out chordae. So the MitraClip will reapproximate the leaflets, and because of that, you have a very low recurrence rate. And this is actually not surprising. We know that if you have a therapy such as just surgical annuloplasty, from some of the surgical trials that have been done, you have a high recurrence rate from just an undersized annuloplasty ring, compared to mitral valve replacement, which has essentially no recurrence. In the CTSN network trial, 14% of the patients had recurrent severe mitral regurgitation at 2 years. And that's because while the ring will keep the annulus small, it doesn't do anything for the underlying tethering issue. And when you have more and more LV dilatation, you'll get more tethering and you can redevelop severe MR. And in fact, this was seen by Alfieri's own work, that he found that a ring only would lead to a high recurrence rate of MR, but a ring plus an edge-to-edge Alfieri stitch would basically eliminate recurrent MR. Now, we can further demonstrate that it's the MR reduction that leads to improved outcomes by looking at the outcomes at 30 days. So here's the baseline 2-group MR severities, all 3 to 4 plus. And you can see at 30 days, 93% of the MitraClip patients had 2 plus or less MR, about 73% with 1 plus or less. In the medical therapy arm, of course, you know, that they had much more MR, but interestingly, about a third of the patients did have 2 plus or less MR. And this may reflect the dynamic nature of mitral regurgitation, maybe slightly better medical therapy or regression to the mean. Now, if we look at the outcomes of all these patients, according to the residual MR obtained at 30 days, and then look at the rates of death or heart failure hospitalization from 30 days to 2 years, you can see that if you achieved 1 plus or less MR, 39% of those patients had an event, relatively low. If you achieved 2 plus MR, it was only slightly higher and actually not even statistically significant. That's the blue curve. But if 3 to 4 plus MR either was not achieved or had recurred by 30 days, then your outcomes out to 2 years were very poor. And you can see when you look at it separately with the MitraClip group on the left and the medical therapy group on the right, that the curves look very, very similar. So it doesn't matter how you reduce the mitral regurgitation. whether it's from the mitral clip or medical therapy alone, or probably any other technique, it's the reduction in the MR and the LV volume overload and the left atrial pressure that is going to lead to the improved prognosis. Now, on the other hand, if you are going to reduce the MR, the second factor is that you have to keep it low. And we also know that while, again, about a third of those patients in the medical therapy group did have a reduction in MR at 30 days, it was less likely to stay reduced compared to the mitral clip group. So here in these first three bars, you see the mitral clip patients at 30 days, the ones that had residual 0 to 1 plus MR. And almost none of those patients through 2 years developed 3 plus or 4 plus MR. If, on the other hand, if you look at the medical therapy group patients who got down to less than or equal to 2 plus, you can see a substantial number do develop severe MR, up to a third of them at 2 years. And now here are the ones who got down to less than or equal to 2 plus MR at 30 days. And again, you could see the mitral clip results are very stable, whereas now 55% of the patients are developing severe mitral regurgitation in the medical therapy group. So again, a lot of that is just some random fluctuation, the dynamic nature of mitral regurgitation. We also know that the mitral clip led to substantially better heart failure symptoms and quality of life. And if you look at this objectively with the Kansas City Cardiomyopathy Questionnaire, you can see very early on, within 1 month, the KCCQ, which was fairly severely impaired in both groups at about 55 points, increased by almost 20 points in the mitral clip group compared to minimally in the control group. And this was a benefit that was sustained out to 2 years. In addition, if you look at the association between that early symptomatic benefit and the long-term reduction in death and in heart failure hospitalization, an early improvement of 10 points in the KCCQ correlates with about a 25% reduction in 2-year death or heart failure hospitalization. So early symptoms portends good prognosis. We know that pulmonary hypertension is one of the most important prognostic predictors of adverse outcomes and in patients with heart failure and secondary MR, and that was the case in the COAPT trial as well. But we found an almost identical influence of pulmonary pressures, which ranged in this trial from anywhere from about 13 to 100 millimeters of mercury in both the mitral clip groups and the medical therapy group. So if you look at the benefit, the hazard ratio reduction of the mitral clip versus medical therapy for death or heart failure hospitalization, it was almost constant across the range of pulmonary artery pressures studied. We also found that tricuspid regurgitation, particularly for medical therapy treated patients, was an adverse prognostic sign. 16% of the patients had this is the pulmonary hypertension, sorry. Here you can see the effect of pulmonary hypertension in the medical therapy group, and here you can see the effect of the pulmonary hypertension in the mitral clip group. So no significant interaction. While it's a negative prognostic factor for both groups, mitral clip improves outcomes whether or not there's pulmonary hypertension. And here's the effect with tricuspid regurgitation. 16% of the patients had moderate to severe tricuspid regurgitation, and that was also a negative prognostic factor, even more so in the medical therapy group than in the mitral clip group. Finally, of course, when we treat these patients, we want to bring their mitral valve gradients down. So we would like it to be less than 5 millimeters. But interestingly, a quarter of the patients in COAPT who were treated with the mitral clip had gradients above 5 millimeters, actually ranging up to 13 millimeters. And in that quartile of patients in which the mean mitral valve gradient was 7, you could see their improvement in terms of both symptoms and death or heart failure hospitalization was equally good as if there was not a gradient. So while we always want to have a minimal gradient, it seems as if with secondary MR and LV dysfunction, the benefits from reducing the severe mitral regurgitation are even more important than leaving a mild gradient behind. This may not be the case with primary MR, where the patients are younger with fewer comorbidities and exercise-induced pulmonary or mitral stenosis is a real issue. But for the sicker secondary MR patients, this seems to be true. So as a result of this, in March of 2019, the FDA approved the mitral clip for selected patients with severe secondary MR who remain symptomatic despite guideline-directed medical therapy. And I won't read the label, but the FDA essentially said, follow the COAPT criteria, because they found that basically all subgroups of patients using those inclusion and exclusion criteria benefit. And this has now made its way into the guidelines. If you meet COAPT criteria and you remain symptomatic, despite guideline-directed medical therapy, you should undergo transcatheter mitral valve repair with the MitraClip. So we are on an ascent to widespread utilization and therefore improved patient outcomes of a relatively narrow part of the segment of populations with heart failure and severe MR who can really benefit by this therapy. First, we had to generate the evidence, which we did from COAPT. Then we had to receive the FDA approval and indication. Then we needed guidelines adoption, and all that is happening. The next big step is CMS reimbursement. And we expected that for about the last 6 months. COVID kind of slowed it down, but any day now we will receive CMS reimbursement. And then we get the heart teams organized with a heart failure specialist, imaging specialist, interventional cardiologists, cardiac surgeons, and general cardiologists to help select the right patients. And that will lead to improved nationwide outcomes for heart failure patients with severe MR who can benefit from MR reduction from edge-to-edge transcatheter vascular repair. Thank you very much.